Thank you so much. So, can we go ahead, sir?
Yes.
So, actually, we were supposed to take first case of exploratory tympanotomy, stepidotomy, but due to patient running high fever, we switched to the subtotal petrojectomy and implantation case.
Yes, sir.
So, subtotal petrojectomy and implantation. We know this is something, expanding the indications of cochlear implantation. Cochlear implantation per se, we know, is the number one rehabilitation for patients having profound sensorineural hearing loss, which are not benefited by the hearing aid. And this subject of cochlear implantation came into light in 70s, and after that, with the gratifying results, the researchers went into it, and now it has established as a number one treatment for profound hearing loss for any reason, for whatever level, if the hearing aid doesn't benefit. So earlier the indications were very, very limited when the implantation came into light, only for selected prelingual, deaf children with certain amount of minimal amount of hearing loss, certain minimal amount of, speech and that kind of strict criteria. But now, in the present context, if you ask me the indications, the candidacy, anybody from any age, from 4 months to, and no limit for the upper age, you can implant 100-year-old patient. So age is no limit. Anybody having profound sensory neural hearing loss, which is not benefited by hearing aid, is the candidate for cochlear implant, provided the basic functioning unit is intact. So what is basic functioning unit? For a cochlear implant to function optimum, it has to have a fluid-filled cochlea. And for the signal transmission from cochlea to the higher centers in the brain, need to have an intact cochlear nerve. So, the basic functioning unit for any patient to be candidate for cochlear implant is a fluid-filled cochlea and intact cochlear nerve. These are the two basic requirements. We call it basic functioning unit for cochlear implantation. If this is intact or available in any patient with profound sensory hearing loss, is a candidate for cochlear implant by and large, without getting into XYZ details. Now the biggest question after the cochlear implant comes, cochlear implant is like a foreign body in the patient's head, in the ear, in the temporal bone. If infection sets in the presence of a foreign body, anywhere in the body, not only ear, we know it is a big challenge to deal with that infection. Even the antibiotics do not work because of the foreign body. Biofilms do form all around, and biofilms, we all know, are resistant to any antimicrobial treatment. Biofilms are what? They are aggregates of bacteria encased in a proteoglycan shell. So even the highest, level of antibiotics in high doses do not penetrate into that proteoglycan shell, and they live happily without the fear of antibiotics and the host immune response. So they are resistant to everything, and those biofilms keep on releasing virulent bacteria from time to spread the infection. So in the presence of foreign body, anywhere in the body, if you get a knee transplant done, infection happens to occur, the ultimate answer is no antibiotics are going to work, and you have to explant the device. And same thing happens in the cochlear implant. So if after the implantation infection sets in, that's a disaster, and you ultimately you can salvage certain number of patients with the best of the effects, but ultimately you have to explant it. And in the otology, in the setting of the ear, it is more important, as ear is fraught with disease like CSOM. So any patient with implant develops otitis media, which is not infrequent, particularly in the children, which are most of the recipient of the implant. If that kind of infection sets in the presence of the implant, it is a disaster, and you have to think, something concrete to prevent such happening, because once implant is there, an infection sets in. The infection, we have already, because of the cochlear implantation, we have opened the inner ear, and we have, inner ear which has a connection with the subarachnoid space. So we have already opened the avenue for the infection to spread even to the brain. So once the implant is in place and infection sets in, it's a bigger disaster, as now you have opened the avenue for the infection to set to the subarachnoid space. So once implant is there, we have to make sure by all means that the infection doesn't set in, and that is the biggest challenge we are fraught with in cochlear implantation cases. So in patients, though to prevent the infection there are many strategies we have been following. We have been doing a judicious workup of all these patients. If there is any previous infection, if there is any CSOMs, we make sure that the patient gets a dry ear, like something like that, the otitis media or otitis media with diffusion resolves, and then we ultimately implant. Another strategy is to vaccinate the patients with the dreaded pneumococcal infection, because most of the dreaded infections in the ear after the cochlear implantation are due to pneumococci. So we have a strategy, and there is a protocol for every patient to undergo pneumococcal vaccination to prevent the infection. So strategies are there, but still there is possibility of infection sets in, because otitis media can happen to anybody, any point of time. And in young children, the incidence is very high because of the maldeveloped, malfunctioning Eustachian tube, because of more propensity to develop URI because of the overall less immunity. And in these children, if implanted and infection sets in, that's a big disaster. So this technique, why I am coming to this subject, this technique, subtotal petrojectomy and implantation, is a boom. Now I tell you how we get into this, how we initiated this subject, and where we have reached so far. Manish sir, can you listen to me? Can you hear me?
Yes, sir. Yes, sir.
Am I audible?
Yes, sir. Very.
So hope people are coming now to the hall.
Yes. Yes, yes.
So,
Yes, boss.
hi, Vishal.
Boss.
So, are you getting something on the screen?
Yes. The role of subtotal petrojectomy in cochlear implant.
Yes. So, this subject is a breakthrough in cochlear implant surgery to prevent so many, problems post implantation. And this, what is subtotal petrojectomy for that matter? Why this is something so important, who have expanded the indication for cochlear implantation. Subtotal petrojectomy was initially introduced in 70s by Professor Hugo Fish. That's a surgery which involves exentration of all air cells into the temporal bone from everywhere, preserving the labyrinth intact. We are exenterating all air cells, including mucosa of the air cells from the entire temporal bone, and then blocking off all avenues for the infection to spread to the temporal bone. Two major avenues where the infection can enter into the temporal bone. One is the Eustachian tube, which we obliterate, and other is the external auditory canal, which we do a cul-de-sac closure, and create a sterile cavity and then obliterate with the fat or something else, whatever you like, or whatever the condition mandates. So this creates a sterile zone in that entire temporal bone after blocking off all external source of infection, all connections to the temporal bone. This is what subtotal petrojectomy is, which I am going to demonstrate. Now, how it is so important in cochlear implantation? As we discussed, any patient after the implantation develop infection through the Eustachian tube or the external auditory canal in the presence of a foreign body is a big challenge. So this technique is proven to be a boom for those patients who are high risk of developing infection post-operatively in the temporal bone, who have high likelihood to have infection post-operatively because of the many reasons, because of the malfunctioning Eustachian tube, because of a lot of nasal region, all those issues, who had otitis media earlier, who had otitis media with effusion multiple times earlier, who had CSOM earlier, which are resolved by medical or surgical treatment, whatever done, but they have a still possibility of, a returning infection into the temporal bone. So all those high risk patients, if primarily we do a subtotal petrojectomy and implantation and obliterate the entire cavity with a fat, the implant lies in the most sterile zone after blocking of all external connections of infection to enter in, is the best way to prevent infection to the cochlear implant. And that is the need of time for all these patients who are high likelihood of developing the, this kind of infection. So, what do we achieve out of this subtotal petrojectomy? Subtotal petrojectomy, see, we exenterate all air cells around the temporal bone. So, this is something which gives even a bigger access or better access or visibility of the each and every landmark in the temporal bone than what you achieve with a radical mastoidectomy. So, it is much more than. So, it provides best of the access and visibility of entire structures. You can't leave anywhere disease behind if there is some disease existing. Suppose you are operating on a cholesteatoma patient. We have a huge series now, same stage, subtotal petrojectomy implantation in cholesteatoma cases. So, it gives the best access and visibility to remove cholesteatoma from each and every nook of corner of temporal bone, because you get a full visibility better than you get with a mastoidectomy. And since we create a sterile zone blocking of all external sources of infection connections, Eustachian tube, external artery canal, so it practically eliminates the risk of future infection coming to the middle cleft. Thirdly, in implantation, there are certain malformations, certain situations where implantation is a high likelihood of developing CSF leak, like certain malformations like IP1, IP3, common cavity. They have a high incidence of CSF leak because of direct connections of the inner ear fluid with the subarachnoid space. So, by means of obliterating, after sealing the leak site, the cochlea, if you further obliterate the entire cavity, give the best opportunity to deal with the CSF leak and ultimate risk of meningitis. And once you stabilize your electrode and obliterate the cavity, it practically eliminates the risk of electrode array extrusion. So, it has numerous advantages once you go ahead with the subtotal petrojectomy. And in implantation, we must know that in a normal implantation, we give electrical hearing directly to the inner ear. Middle ear external auditory canal doesn't participate in the hearing after the cochlear implantation. So, in subtotal petrojectomy, once you eliminate the middle ear and the external ear and obliterate the entire cavity, it doesn't affect the prospects of cochlear implantation, because practically they are not any more used after the implantation. Role of middle ear, external ear is no more after the implantation, which we remove in subtotal petrojectomy. So, there is no disadvantage of doing in this technique in any given case. So, indications are numerous. The biggest question is, what cases are the best ones where we can choose subtotal petrojectomy implant? Any patient with CSOM happens to develop infection again after the implantation is a disaster. So, any patient having CSOM, who had CSOM, who has high likelihood of CSOM, better to do a subtotal petrojectomy implantation and create a sterile zone and forget about the future infection, rather than taking a risk of a regular implantation and then struggling with the post-operative infection. This, as I said, gives a better exposure than the radical cavity. So, those patients who are already having a radical mastoid cavity, how will you implant otherwise? You can convert to a subtotal petrojectomy implant, so easier for them. All difficult implantation, ossifications where you need drilling, you need more exposure to control the carotid around, this gives the best exposure. Malformation we'll discuss. Fracture temporal bone, again there is high chance of CSF leak. Osteoradionecrosis, the bone is affected by the vascularity itself. A regular implantation can post-operatively, the temporal bone can acquire infection. Any revision surgery with loss of landmark, this and that, convert to subtotal pituitary implant. Any unfavorable anatomic condition which you are not able to deal with in regular implantation. There is a very high jugular bulb, very forward sinus, facial nerve abnormality, anything abnormality which you are not able to deal with in a regular implant, go ahead with this, because this will ultimately give you the best of the exposure, like an open book. So, and the most importantly, it has expanded the indications for cochlear implantation. Like for example, we have now huge series of patients, वहाँ का पिक्चर लगाओ ना, आ रहा था ना उधर का. So huge series of patients who have undergone major lateral skull base surgery and yet benefited with the cochlear implantation at the same stage. Like patient operated for glomus jugular, patient operated for even limited acoustic neuroma, or any other n number of tumors are there in the lateral skull base surgery. So any patients after the major lateral skull base surgery can be implanted same stage, provided, as I already mentioned, the basic functioning unit is intact. And what that is what? The intact fluid filled cochlea and intact cochlear nerve. Huh? So any patient even after the major lateral skull base surgery, if the basic functioning unit is intact, we have done number of patients of glomus surgeries with profound sensorineural hearing loss implanted at the same stage. So this is something opened a new gateway, new indications, number of indications for rehabilitation of hearing loss of these poor patients. So indications are numerous. Our entry into this subject happened after this publication, which Mario Sana, who is the leader, who innovated and applied this technique of subtotal pituitary in the implantation for the first time, and had a series of 32 cases of various indications, published long-term results, and found this technique to be better. So we initiated our course in this subject, our journey into this subject after this publication. Then another publication from Mario Sana of 110 cases, after of this technique, is really something opened the eye world over to adopt this technique to prevent infection in these patients. And we have now even a bigger series of such cases, subtotal pituitary implantations, for even more, I would say, a variety of indications now. So any patients having basic functioning unit intact even after the major lateral skull base surgery is a candidate for cochlear implantation to rehabilitate the hearing. So why, as I already mentioned, the returning infection is the risk. That's why. And if the infection returns, suppose you have done a regular implantation and unfortunately the infection happens to return in the temporal bone with a cochlear implant in place. There are two main concerns, I tell you. Number one, we have already opened the avenues to the inner ear and subarachnoid space by opening the cochlea. So there is always a possibility of labyrinthitis, meningitis, even the implant extrusion. And in spite of the best efforts, if you try to remove the biofilms and all, it is so difficult to do a revision surgery in the presence of CI already inserted. To drill all around the cochlear implant is so difficult. So these are the high risk cases for post-implant infection, and we have to think primarily in such situations that the infections are likely to happen. Why not to adopt a subtotal pituitary implantation as a first scene, as a first technique, rather than doing a regular CI? Because in any case of CSOM, the CSOM can recur in the best series of the world. No one has claimed 100% results so far in long run. I tell you, even in the situation of type 1 tympanoplasty, myringoplasty, the initial success rate is more than 95%, in the best of the hands 97%, 98% initial results. But what about 10 years down the line? The patient many a time develops infection again, otitis media, a reperforation and all that, and no study so far has claimed more than 70% results 10 years down the line. We know, we see in our patients a successful tympanoplasty done, and the patient coming after a couple of years or couple of months with an infection in the ear or perforation again. So any patient with tympanoplasty can develop reperforation. We have no control over the Eustachian tube and nasal issues for long term. So why not to implant such patients for this and forget about the infection ever? And these are the patients. One of our indications for today's patient is here. See, any patient we know who has a known Eustachian tube dysfunction is likely to, affect middle ear sometime with the otitis media again and again. Why not to subject such patients for subtotal petrosectomy implantation in the first go? Because if infection sets in, we all know what is going to happen with the implant in place. Today's patient had cleft lip and palate, and because of the cleft palate, he has a repeated history of, otitis media and effusion. He has a fluid, he has a retracted drum, and he is not, going to be benefited by any conservative management forever, because the Eustachian tube malfunction is congenital because of the malfunction of the muscles controlling the Eustachian tube, which are affected in the palate. So these patients have a high incidence of repeated otitis media infection, atelectasis, cholesteatoma. So they are going to bother the ear lifetime. And this patient having bilateral profound loss is the ideal candidate for subtotal petrosectomy implantation. This will involve blocking of or obliteration of the Eustachian tube and the extra-auditory canal, removing entire cell, mucosa, epithelium, everything from the temporal bone, and then implantation. That will create a safe zone, sterile zone, and will obliterate it, and that will ensure that whatever Eustachian tube dysfunction was is not going to affect the ear after the implantation. That's the goal in this patient. Patients having immune deficiencies are likely to acquire infection again and again. Patients having recurrent, adenoid issues. See, most of the patients implanted so far are children. So majority of the candidates are children and who have high incidence of adenoids, allergy, CRS, immunosufficiency, recurrent otitis effusion, or tubercular otitis media. These are the patients who are high risk patients to give problems again and again. And these are the real candidates, once they are candidates for CI, to consider subtotal petrosectomy as a primary approach at first seen, rather than trying a regular implant, then recurring infection and struggling with the infection, and ultimately ruin the prospects of implant. So these are high risk cases we must take into consideration. Like we take some scenarios. I am taking some scenarios. For example, central perforation if somebody has, and a profound hearing loss. What are the options you have? The option number one is to do a tympanoplasty first and do a second stage CI after 6 months or 12 months when everything, the ear is dry, no infection, that the graft taken up, everything. That is one scenario, and the other scenario is the same stage, rather than staging it, same stage, subtotal petrosectomy and CI. You can do the other thing, the tympanoplasty in second stage. But the problem is, who can guarantee that the tympanoplasty will not fail in long run? The patient will not develop otitis media in long run. See, the patient requiring tympanoplasty, patient having had long-standing perforation, how can you ensure the long-term Eustachian tube results in 100% of the patients? And since middle ear is never going to participate after the cochlear implantation anyway, middle ear and external ear, why not to do a subtotal petrosectomy in CI for once and ever and eliminate all future sources of infection? I told you, no long-term study in the world has shown more than 70% results, even 10 years down the line, even for the type 1 tympanoplasty. We have seen in our practice, a patient operated for central perforation, meringoplasty, type 1 tympanoplasty done, graft taken up, doing so well, and after couple of months or couple of years coming back with a otitis media or perforation. This can happen. Imagine that situation in that patient. After in such patient, when you do a cochlear implantation and patient come back with the infection with the implant in place, how difficult to deal with that. And since the middle and external ear do not participate after the cochlear implantation, that's a direct hearing to the inner ear, why not to ablate them and prevent a future source of infection. So this technique has to be taken into consideration with the patient prospects. Atelectasis. Patient having retracted drum, some otitis media effusion, you have an option of doing a canal wall or canal wall down or up, whatever. Canal wall up tympanomastoid surgery, and after 6 to 12 months you have reconstructed the canal wall with cartilage, eardrum with cartilage, everything nice, and do a second stage CI. Or you can do a subtotal petrosectomy CI. The difference is with the second stage after the canal wall up and all this, how can you ensure 100% results down the line, 10 years down the line, 5 years down the line? If the Eustachian tube malfunction or anything sets in, nasal issues, anything sets in, the infection is likely to return. So why not a subtotal petrosectomy CI in one go? Since the middle ear and external ear is never going to participate, even if you preserve them, anyway they are never going to participate in hearing after the implantation, but they give a source of infection. This is very, very important. Cholesteatoma surgery. Cholesteatoma, we all know, the primary goal in cholesteatoma is to make the ear safe. Not the hearing, not the discharge, the primary goal. Without compromising the primary goal, the other goals are useless. So primary goal is to make the ear safe, and you can do that by a canal wall or canal wall, up or down mastoidectomy. If you have done, and after a mastoidectomy for cholesteatoma, after waiting for 6 to 12 months, you can do a CI. Who can ensure the patient is not going to develop the cholesteatoma again in long term? Who can ensure this patient is not going to develop Eustachian tube issues or otitis media effusion? Patient who have already developed too severe a disease like cholesteatoma, which has been long standing, are probably due to Eustachian tube malfunction, how can you ensure for the further life that everything is going to become normal and you can implant? If the infection comes back, it's a disaster. So these are the cases for subtotal petrosectomy. If there is active infection, we treat first, or we do a subtotal petrosectomy and obliteration, and after 6 months or so, 4 to 6 months, when everything, the fat in place, everything sterile zone is normal, then you can do a CI or control the infection and do the CI at the same stage. We have done number of cases of cholesteatoma and cochlear implantation, so far all in the same stage. No active infection, little bit dormant infection is always there with cholesteatoma. But in this, you exenterate each and every cellular area of temporal bone, including the skin, mucosa, everywhere, and you don't leave anything behind, and you can ensure that the infection is not going to come back once you obliterate, and after blocking of further sources of infection, you take a tube and extraordinary canal. Imagine the situation of a patient who had been operated or a canal down mastoidectomy and has a profound hearing loss. What can you do? If you don't have this technique of subtotal petrosectomy, what are the options? Option is you elevate the epithelium layer from the cavity, implant and replace the epithelium. And the implant under the epithelium, you all know the canal down cavities are infected so often. With a single layer of epithelium and the implant underneath is likely to infect the implant so often. To prevent that, you can do elevate the epithelium, put some muscle or soft tissue or cartilage, and then put the implant underneath to protect them. But still, who can ensure that the cavity is not going to get infected? Since middle ear is not going to participate in the hearing after the implant, why not to remove everything from the mastoid cavity? Why not to convert to a subtotal, obliterate all sources of infection, Eustachian tube, extraordinary canal, implant, and obliterate the cavity and forget about it forever. This is something, a sure a sort of, if properly executed, a short technique to prevent post-operative infection. So these are certain otitis media infusion again is a very tricky situation. Children very often, a lot of people recommend you do a CI and put a grommet at the same stage. You do adenoid surgery, do whatever, treat the nose, and yet nobody can guarantee the OME is not going to return. Children particularly with a less immunity and poor Eustachian tube function are likely to again get the OME in any scenario of infection or anything or allergy in the nose. They can develop OME, and that's a disaster. So children, what we believe personally, children who are getting otitis media with effusion again and again are likely to happen even after the implantation. So why to take a risk, and why not to do a subtotal peterectomy implant at the same stage? That's it forever, because we are blocking of Eustachian tube. So no, whatever going in the nose, allergy, CRS, adenoids, whatever going in the nose, let it be. Deal with that separately, but you can ensure a sterile cavity for the implant to prevent future infection. So this is something, a boom for such patients, and we have to think over it. See, this is the lacuna, and this is something happening in our country or probably everywhere. This kind of nasal workup, intense nasal workup, Eustachian tube workup, probably not happening before every implantation. And one of the reasons is the government schemes also. Number game also, I have done 1000 implant, 5000 implant. That thing is also going on, and which may give a possibility of overlooking, such high risk patients and implanting them first by the regular technique invites a lot of problem. And we have witnessed, even I got so many revisions, we have witnessed a lot of revision implant surgeries because of the infection coming for various reasons. So this is something very important for us to think over it to prevent infection in regular implantation by avoiding a regular implantation in this high risk scenario patients. Only in high risk scenario patients. Those are regular patients who do not come in this category of high risk which I mentioned here. You still can implant on a regular basis, and we have been doing a regular implantation. Another subject is inner ear malformation. Now implantation is very getting popular in inner ear implantation, and in our practice we have been doing for all malformations, all inner ear malformations. We all know malformation means the maldeveloped cochlea, vestibule or labyrinth, whatever. In those scenarios, many of the malformations have direct connections of the inner ear fluid to the subarachnoid space, like most commonly in IP1, IP3 and common cavity. In this scenario, the moment you open the cochlea, you will get a gusher. Though you can control the gusher by sealing the cochlea at the same time. You can. But how can you ensure that the seal is going to be perfect forever? Because you have opened the avenue directly. If infection sets into the subarachnoid space, there is direct subarachnoid space which is giving gusher. Best is to seal the cochlea and obliterate the entire cavity to prevent any possibility of CSF leak in future. So any patients with a high risk of developing CSF leak or develop CSF leak during implantation is ideal candidate for subtotal peterectomy, which is the best technique to ensure that the CSF leak is not going to happen because of entire cavity obliteration, which gives additional protection to prevent CSF leak. That is something important to understand. Obliterated cochlea are very important. These are most challenging patients, I believe. Patients having partially or completely obliterated cochlea, hardly any lumen to insert the implant. What can you do? Still, if there is some lumen somewhere in any of the ton, still you can try. We have done even double array, 3 array, 1 array in basal ton, 1 in the middle ton, 1 in the or whatever in the sometime the scala tympani is completely ossified. So you can implant in the scala vestibuli because this ossification starts from the scala tympani, close to the round window where cochlear canaliculus opens or the cochlear aqueduct opens, which is probably the source of infection from meninges to the inner ear. So initially starts in the scala tympani or basal tongue close to the round window and then spreads everywhere. So ultimately, even in the most obstructed cochleas, if there is the smallest possibility to lumen, we do implant to insert whatever number of electrodes, not completely, even the partial array has a beneficial effect. So, and that requires lot of drilling of the cochlea. See, the cochlear drilling is so tricky, you need good exposure. You need to have exposure of the carotid artery anteriorly, which is in closest proximity. The jugular bulb is below. So once the cochlear drilling is required, you need to have a best of the exposure to control all the structures, and this is something, best of the technique we have found in cochlear drill outs. Once you are doing drill outs, do a subtotal petrosectomy. It gives bigger exposure than a radical mastoidectomy. Your carotid artery is in your view, jugular bulb is in your view, everything under control, and then you can drill out the cochlea safely. You can do all turns drill out, complete drill out, whatever, once you have a good exposure, rather than, imagine if you are doing a drill out through the posterior tympanotomy. If you intend to do a total cochlear drill out, all turns, through a narrow window posterior tympanotomy, how unsafe it is. How can you control all the structures around, and you are practically putting the patient on the risk. So these are the candidates for cochlear implantation with subtotal petrosectomy technique. So there are n number of indications. See, temporal bone fracture, for example, any fracture of the temporal bone, you can do a regular CI. But the problem is the fractures of the temporal bone do not heal with the bone, they heal with the fibrous tissue, and there is always possibility of infection from the temporal bone. Suppose patient develop otitis media to spread to the inner ear space more often, and if you put an implant in that scenario and infection sets in, is a disaster. Better to do a subtotal petrosectomy. Osteoradionecrosis, the bone is infected because of poor blood supply, and if you put a CI, then is a disaster. So you drill away the entire bone, and this is the only scenario where we put a vascularized muscle flap rather than the free fat, because that gives additional vascularity to the poorly vascularized bone because of the radiation therapy. So this is something where subtotal petrosectomy is the only technique which can work. Any unfavorable anatomical condition, any revision surgery where the XYZ everything is distorted, high jugular bulb, low dura, high sinus, carotid abnormal, facial nerve abnormal, semicircular canal abnormal, round window is abnormal, not looking in the regular place, rotated, whatever, do a subtotal petrosectomy, everything open book like situation in front of you, and then implant, rather than struggling and giving complication. So these are various indications along with skull base lesions where you can implant. So advantage, what we have discussed so far, the advantage is you can eradicate disease from the temporal bone anywhere with this kind of extended exposure. So that creates the safe environment for the CI. After blocking of all connections, the Eustachian tube extraartery canal, preventing avenues for the infection to come to it, best visualization, access, exposure, anything, whatever you think is best with the subtotal petrosectomy rather than the narrow approach. And like in cochlear drill outs, if you have done a drill out even by the narrow technique, the arrays are open now. How will you stabilize the cochlear electrode arrays? Obliteration is the best way. Once you obliterate everything from above, everything is stabilized. So this is something important in patient with malformations where the CSF leak. Control is best with obliteration, and once it is done, it eliminates any care. There is no cavity. You obliterate everything, no cavity care. Just do and forget about it. Yes, the follow-up, radiological follow-up is important. Like any other surgery, it has also contraindication. So if you are operating in a scenario of active infection, obviously it is contraindicated. That's a regular contraindication for any surgery. If you are doing for cholesteatoma and not sure of complete removal, better to stage or wait or not to do it. So that is regular way of regular contraindication like any other thing. Risk like any other surgery. You obliterate with the fat. Fat is the best material to obliterate, but the fat can acquire infection. You have to do something. Your blind sac closure has to be good. Otherwise, if it breaks down, it's a disaster. Cholesteatoma, if you left behind, it's a disaster. You have to exenterate each and every cellular tract along with the skin. You know, this scenario of cholesteatoma leaving behind is highly unlikely. With this kind of exposure bigger than the radical mastoidectomy, you can't leave a skin behind. You know, what the bigger challenge is, the cellular tract left behind. If it is too pneumatized a mastoid, going to the petrous apex, you have to exenterate also. Leaving the mucosa in the cell is a bigger, problem than leaving the epithelium. Because if you leave too much of mucosa behind, the mucocele is going to happen, because now there is no more aeration from the Eustachian tube coming. So, entrapped cholesteatoma is a less likely scenario, but mucocele formation is more likely if you don't exenterate the cells, properly. There are certain disadvantages. You do the cul-de-sac close, aesthetic issues are there. So, what we do, we sink the extra-aortic canal little deep, or suturing, so that it doesn't look ugly. It looks like from outside seen, it looks like a feeling of a canal, not obliterated one. And obviously radiological follow-up is very important. Once you obliterate, you have to, the only way to see what is happening inside is radiology. You can't see from anything from the outside. If mucocele is forming, cholesteatoma is forming, only way is radiology. So that is mandatory from 1, 3, 7, 10 years down the line. And in case, even in the most unfortunate situation, if re-exploration is required, like any other revision surgery in the body, re-exploration is more challenging. Though in this scenario, it is not so much. Whatever fat you have obliterated, remove the fat in one piece, and you see everything the same cavity like there. We have revised one of our case, and after the fat removed, everything looked like the same cavity we operated 1 year back. So this is something more simpler than any other revision surgery in case required. Radiological follow-up is very important to detect the cholesteatoma. Sometimes it is difficult, but what happens? The cholesteatoma has a different intensity than the regular fluid, and with in a slightest of the doubt, you can follow it. If it is increasing, then you have to re-explore. Why this? The CT is done most often because the MRI is a challenge because of the magnet in place, lot of artifacts. The MRI after the implantation is a big challenge. Though nowadays MRI, compatible implants are there, but still the MRI, the magnet is a big artifact and it doesn't give a true picture. So mostly we do a CT scan done unless the symptomatology or some complication demands. So I will conclude this technique as one of the best technique for many indications I have mentioned, and the best way is to create a sterile zone for the implant, all around covered with the fat, all external connections blocked by blocking Eustachian tube and extra-aortic canal. No futures of infection incoming to the temporal bone is left behind, and this is what we want after the implant. So this is one of the best technique. And in today's case, see today's scenario, see this patient CT scan. I am not going in the details of the CT scan, as we are operating on the right side. See the intra-aortic meatus, the cochlea, vestibule, all normal, all 3 tons of the cochlea, cochlear aperture, the modulus, everything looking good. See, this is the bone of the modulus looking good, all anatomy intact. This is jugular bulb, this is cochlear aqueduct, this is round window zone. See this? Now what is there inside the middle ear? See this? Full opacity in the middle ear, because patient had a cleft palate, patient has permanent Eustachian tube malfunction, repeated otitis media, atelectasis, and see this kind of the picture in the middle ear. How can you do a regular implantation in this case? If you do a regular implantation in this patient, it is bound to be, explanted very soon, because the infection is bound to happen as the Eustachian tube function is permanently, poor. And see this scenario, in this scenario, the only technique which permits the implantation to rehabilitate this patient is subtotal petrosectomy. See this. So this kind of a picture, and today's this case we are going to do a subtotal petrosectomy and implantation, and now we'll start our surgical course soon. Before that, any questions? Anybody regarding the indications, the viability, the complication, contraindication of this technique? This is something a boom. And hello, sir.
Dr. Simas here, sir.
Yes, sir.
In such type of cases, is there any particular implant which we give?
Not
Regular one?
see. This is a normal cochlea. We are not doing subtotal petrosectomy for any malformation. We are doing subtotal petrosectomy because of the repeated incidence of otitis media, because of the cleft palate and malfunctioning Eustachian tube. So as far as the implant is there inside the cochlea is going to be same. So we have no, bias regarding any implant. I do all complete implants, whatever patient likes, with the same capacity and same vigor. So I have no particular choice for any other company. But for this normal cochlea, any implant is good. Had there been a IP1, I would take a compressed array. Had there been a hypoplastic cochlea, I would use a small compressed array, something like that. Had there been a obliterated cochlea, I would keep ready the 2 array, triple array, double array implant, whatever. So according to the cochlear situation, you have to choose the array. This is because of the middle ear pathology we are forced to do this. We are biased towards subtotal petrosectomy because of the malfunction Eustachian tube and middle ear pathology. It's nothing to do with the implant choice. Any other question?
Satish, Dr. Jaswal.
Yes, boss. Good morning.
Morning.
Oh.
Radiological follow-up post-surgery.
Yes.
How often and when?
Yes. So our first radiological follow-up after subtotal petrosectomy is at 1 year. After the implantation, we are biased towards getting a CT scan done. If we find anything, any symptomatology or any problem to the patient mandates us to do a follow-up, or CT scan shows some abnormal thing, then only we will do a MRI, because if you do an MRI, you have to remove the magnet. Otherwise, the artifact won't allow you to see the structures carefully. So most of the time we get away with CT scan with no complaint in the patient and CT scan getting normal. Why to go in for MRI? So first follow-up, first choice is CT scan. Unless the finding, any positive finding in the CT scan mandates. Welcome Dr. VP Singh sir, our hero of the tournament. Most inspiring person in this tournament is Dr. VP Singh. Believe me, he's here with us in the theatre, and it is not for the first time we are playing with him. We have played many tournaments in Jaipur, in Agra, or in Dubai together, and he is the one who inspires us a lot. What a wonderful personality, human being, and a player he is. Welcome, sir.
But unfortunately, the last 3-4 balls. Any comment?
Yeah, that is actually the Rajiv boss. I don't know what was the rift was going on between the captain and the VP Singh boss. So I think Rajiv boss made him run out. That was not actually a run, and he unnecessarily asked him to run and made him run out. So it looked like the captains, sometimes captains do such crook behavior to get some players out, because they are superseding them. So this is all politics, I think, which got him out.
तो ये सब जब कहते हैं जो आदमी बेईमानी करता है ना, तो बेचारा बंद कर बस इसको बेचारा कहाँ से कहाँ यहाँ बॉल लग रही
नहीं है बेईमानी का, प्रॉब्लम ये है कि बेईमानी करके हम उसको प्रेजेंट कैसे करते हैं।
साजिश हुई है मुझे।
There is a question.
मेरे को तो लगता है बॉस, खन्ना बॉस, मुझे लग रहा है वीपी सिंह सर के साथ साजिश की गई थी। कल उनको जबरदस्ती रन आउट कराया गया। रन था ही नहीं, वो हाथ में बॉल थी, कहाँ का रन था?
चाय में दारू पिला दिए।
ये तो मान लो क्रीज के पास पहुंच गए, इतना तेज भागते हैं घोड़े की तरह, अगर कोई दूसरा था तो आधा क्रीज भी पार नहीं कर पाता, आधा पिच भी पार नहीं कर पाता। ये तो ये थे इसलिए पार कर गए।
5 किलोमीटर की रनिंग की है।
हाँ तो
आज सुबह सुबह मैंने देखा 5 किलोमीटर रनिंग कंप्लीट किया है।
हाँ तो इनको तो बॉस ने जबरदस्ती आउट किया, इनकी परफॉर्मेंस खराब करना चाहते हैं, इनको बुढ़ापे का ताना दे दे के रिटायरमेंट करना चाहते हैं ये जबरदस्ती। इनके साथ अन्याय हो रहा है। मैं सर के साथ हूँ, वीपी सर के साथ साजिश हुई इनके साथ।
आफ्टर विनिंग द लास्ट मैच आप उनके साथ हो।
वो यार हमको हमको गर्म खाना खाना था, थोड़ा सा कुछ माहौल अच्छा रहना था, इसलिए करना पड़ा। नहीं तो पता है ठंडा खाना मिलता तुमको?
खाना भी नहीं मिलता।
खाना नहीं मिलता।
मेरे को वहाँ लग रहा था खाना भी नहीं। So anyhow, there is a question.
Yes, please.
What about antibiotics? Any preference for the antibiotic you give after this?
Antibiotics, broad spectrum, no specific, and antibiotics have hardly any role.
Okay, but any choice of antibiotic from your side? What do you give?
Yeah, we give for initial couple of days, because we all know the Pseudomonas is a dreaded infection. So Pseudomonas directed injectables for couple of days, most likely ceftazidime as a primary one, or cipaparazone subjectum for as a not culture directed or anything, as a primary antibiotic for couple of days to prevent such infection.
Any questions?
So idea which I wanted to pour is this technique is a boom in many situations. It can prevent the surgeon falling into trouble with a regular CI in many high risk situations which have a high likelihood of giving infection. In this particular patient, you look at the CT scan or the picture of the middle ear and so. Patient has atelectasis, patient has repeated OME, and this is going to happen lifetime because there is permanent malfunction of the Eustachian tube because of the cleft palate scenario. So in this scenario, if we still go in with the regular implant, the implant is never going to work. The infection is going to set in, and if infection sets in the presence of an implant is a big disaster. Disaster for two reasons. Number one, after the implantation, we have already opened the avenue for the infection to spread to the inner ear and the subarachnoid space because we have opened the cochlea. So, if in the scenario we have already opened the cochlea and the infection sets in, it can spread to the subarachnoid space, meningitis, and even can be fatal. Number one. Number two, controlling the infection after implantation is a big challenge with a foreign body in place. Biofilms are likely to follow, and with a foreign body in place, even the most of the best of the culture directed antibiotics do not work. They do not penetrate the biofilms. Biofilms are what? They develop preferentially on such surfaces, uneven surfaces which cochlear implant electrode array and the implant or the base of the implant offers. So if biofilm forms, biofilms are what? They are aggregates of bacteria encased in proteoglycan sheet to protect them from host immunity and the antibiotics. So in the presence of the biofilms, even if you give 1000 times concentration of the antibiotics from the regular one, it is not going to penetrate. So infection in the presence of a foreign body is a disaster. So in this scenario, like Eustachian tube, which is bound to give repeated OME and middle ear infection, if you implant with a regular technique, is going to be a disaster. This technique, after the subtotal petrojectomy, we exenterate all cell tracts of the temporal bone, which I am going to show you now. We block off the source of external sources of infection to the temporal bone by means of obliterating the Eustachian tube and cul-de-sac closure of the external aortic canal. We create a sterile zone, remove all mucosa epithelium cells from the temporal bone, implant them, and then obliterate with a fat to create a sterile cavity to prevent future infection. And this is the need of the hour in such patients. Otherwise, they cannot be rehabilitated by regular technique. So this is the time is to think of such technique in high risk scenarios. Patient who have a high likelihood of developing infection after the surgery are the real candidates for this technique, which practically rules out the possibility of future infection. That is what I wanted to say. Any further question before we proceed to the surgical part?
Any questions, please? We have seen Mario Sana. He's a fan of this procedure.
Yeah, he actually published a large series initially.
Yeah.
So, and another thing, after this technique, you can implant in any worst to worst scenario patients, even after the most major lateral skull base surgery ablations, even after the major glomerular surgery, even after the acoustic neuroma surgery, anything after any lateral skull base surgery, you can implant if the basic functioning unit is intact. What does it mean? Basic functioning unit for a cochlear implantation is fluid filled cochlea and intact cochlear nerve. After the major ablations, if your cochlea is fluid filled and intact, left behind, your surgical resection has not involved the cochlear resection, and the cochlear nerve is intact, you can still implant. And we have done number of implantation after major lateral skull base procedure, and that is something which can happen only with the technique, this technique. So this is the boom, and so we are going to start this surgery very soon, and I am operating today from our prestigious center, the Narayana Hospital, the Narayana Multi-Speciality, and I am part of this center for more than almost 10 years now. And this is a multi-specialty center, very well equipped. The child is 1 year old. Child has a single, lung. It's a challenge, medically challenged patients, and this happens here because of the strong anesthesia team. And I am working with, I am indebted to our chief anesthesiologist, Dr. Pradeep Goyal, who is a cardiac anesthetist and who takes up such challenges. I have done many medically challenged patients, even 98-year-old patient having 15% ejection fraction, patient having, running atrial fibrillation, this ventricular morbidity, running any medical comorbidity is not unfit here. Practically any patient walking to the hospital is a medically fit according to him, maintaining those parameters. That is how they work, and this is something real boom to such patients, and I am indebted to the Narayana team and happy to be associated with them and regularly operating here for all such challenging patients. And here in our team is Dr. Dipanshu, who is in our surgical team also, playing from the cochlear side. He is the senior consultant ENT at Narayana, and we are working in close collaboration. So, do we go ahead to the surgical part or any other question?
Yes, we can go ahead as we have to leave by 1:30.
Yeah, that I will finish. 1:30 is last. I will finish by 12:30. So you can have your lunch, and I'll request you to be in buses by 1 o'clock, so that we reach the ground 1:30. So as to maintain the schedule. So I'll finish it before 12:30. And if you want me, I can finish even earlier. No issues.
Take your time.
Not a problem. So before starting the surgery, I'll just quickly show you what is basic functioning unit. Can we look at the MRI? Though we don't have the MRI in DICOM format, but still I can show you. This is very important. In DICOM format, you see much better, and it is important to. और वो दो ना बाकी MRI. बाबू बाकी MRI निकालना. So just I will show you with the external camera. इधर लाओ, इधर लाओ. इधर आ जाओ. ये वाला लगाना. ये लगा. Hello. The right ear we are operating. You can see this T2 weighted MRI, heavily T2 weighted MRI, and what you see is the fluid filled cochlea. Even in the regular T2 sequence, you can see the fluid filled cochlea. Can you see the bright Fluid filled cochlea. Can you focus here?
Can you focus a little bit? Yes, yes.
Zoom, zoom, zoom.
Yeah, you.
That is a bright fluid filled cochlea, and in the drive sequences you can see all the nerves emerging from the cochlea very common. In the DICOM format I could trace the nerve right from the origin till the subarachnoid space, but since we do not have MRI on DICOM, it's only pictures, so still we can see the basic functioning unit, the cochlea, fluid filled cochlea and the intact 8th cranial nerve. Cochlear nerve intact. This is the basic requirement for any cochlear implantation. So if you ask me the candidacy for the cochlear implantation in the present scenario, any patient having profound hearing loss which is not benefited by hearing aid is the candidate for cochlear implantation, provided the basic functioning unit is intact. That is a fluid filled cochlea and intact cochlear nerve, whatsoever the age and other factors are. You can implant 100-year-old patient, you can implant 4-month-old child at any age is not a criteria. The criteria is it has to have a basic functioning unit intact. So we are going for the wash up, and so starting surgery in couple of minutes. During surgery also feel free to interrupt me for any questions or suggestions for the healthy discussion for the benefit of everybody. Thank you so much. कहाँ गए अपने सर कहाँ गए? सर बोले तो हुआ?
Hello.
Yes, sir. Are you getting microscopic picture now?
Yes, we are getting very clear. You have to just focus it.
Yeah. So I am operating on the right side, which I had shown you in the scan. Section. So this is 1-year-old child, profound deafness, bilateral profound deafness, cleft palate, some wax in the canal, whatever. Anyway, so the surgical steps for the subtotal petrojectomy. See, subtotal petrojectomy is a technique which was devised by Yugoslav in 70s for other regions as an approach to lateral base skull base procedure, as an approach for the most resistant, ear infections. So the technique involves exentration of all cellular tracts from the temporal bone, all skin, mucosa, cells, everything, keeping the labyrinth intact. Labyrinth is undisturbed, left undisturbed in subtotal petrojectomy. And then you block off all external sources of infection, connections, avenues to the temporal bone. That is obliteration of the Eustachian tube and cul-de-sac closure of the cul-de-sac closure, and then finally obliterate with the fat. See, the incision is same like your regular implantation. Is the picture good there, sir?
Yes.
Incision is
All because of Dinesh.
Yeah, Dinesh is the. I am so addicted to Dinesh. So fan of his work, and we always do workshop with Dinesh only, and feel so confident about the audiovisual part. Even our, cricket tournaments, audiovisual work, entire thing, the screen, replays, third umpire, audiovisual, everything, live transmission is all done by Dinesh. Dinesh does transmission for the Hotstar also. Hotstar transmit all international matches, IPL matches, and Dinesh is the part of the team there to transmit all. So always grateful to Dinesh for his services. See now, the same regular incision. Now I am not going muscle deep from the beginning. My flap should not be too thin or too thick. Which flap? The inner one. This has to be, which is going to cover the implant later on. And utilize cautery minimum to prevent tissue loss, to prevent secondary infections. See, this incision respects all vascularity surrounding the ear. This ear and the auricle, this entire pinna is supplied by vessels from all around. Anteriorly, superficial temporal artery, below and behind the occipital artery, below posterior auricular artery. This incision and this flap raising respect all those vessels. So this is that's why a very popular incision for the otology surgery, and same here for the implantation. See, in this, in the regular implant, we do not open the canal, but in this, we have to open the canal, and I am circumferentially transecting the canal like this. This is the lateral part of the canal, where we are going to do a cul-de-sac closure. See this canal which I have transected above? Hello?
Yes, yes.
Now, in cul-de-sac closure, which is a very common, procedure for many other regions, what you need to do, this is the canal skin. See this? And circumferentially all around is the cartilage. So you have to separate this canal skin from the cartilage all around, and that make a sleeve and bring it out and suture it. And then further, after suturing the canal laterally, we reinforce from below with both the cartilages. Both the cartilages means, see, this is conchal cartilage here. We all know this is conchal cartilage. Frequently we deal with in mastoid surgeries. And anteriorly this one is what? Tragal cartilage. Can you see? So after the canal sleeve taken out, we reinforce below by suturing these two cartilages underneath to give a secure, stable cul-de-sac closure which should not open. That is very, very important to know. So the cul-de-sac closure is what? You bring the canal skin out, suture it with a, we use a vicryl suture, non-absorbable sutures, so that they no need to be removed, strong sutures, because this cul-de-sac breakdown, if happens to occur, is a disaster. So we have to make sure the cul-de-sac goes smoothly and strong. See the cartilage being separated of the skin. So we have to make the sleeve of the skin to bring it out. The extra cartilage being removed. And see the sleeve of the skin, only skin, carefully not to give buttonholing. If happen, doesn't matter, you can resuture, but still bring the sleeve out. See, below is the tragal cartilage. That is the anterior cartilage. Posterior cartilage you have already seen behind, that was the conchal one. Yeah. So this sleeve is created and pulled outside and sutured. Such a simple technique. just only the skin has to be separated, and it is tightly tethered onto the cartilage, tightly tethered. So be careful not to, see now being pulled out. Now the important thing is you don't have to pull a long sleeve of skin. If you pull a long sleeve of skin, your suturing is going to be more and more lateral. We are not pulling the long sleeve of skin, so our skin is not coming more and more lateral, and it little bit dips down with period of time and gives a feeling of an exnotic canal from outside. So doesn't give, so it is cosmetically acceptable. Otherwise, if you pull too much of skin out, which is projecting all the time, is not cosmetically acceptable. So this is important to remember. You don't have to pull too much of skin. See this? Pull the skin, pull the edges out so they do not ingrow. And this is vicryl, non-absorbable, so it stays for couple of weeks, so it doesn't allow the suture line to break. You don't have to remove the stitches which can allow the suture line to break, and ultimately it gives a stable closure. Ultimately what we want, we don't want this skin to allow to ingrow. So this is first suturing lateral. So the direction of the skin is pulled outside. This is not going to ingrow. That is the bottom line. We should understand. So this is very important. And see this technique doesn't take more than 10 minutes. This is required in many of the procedures, and we can do it so easily. Anybody can do it. This is simple to understand and execute, and in a proper way so as not to give any problem. A breakdown in cul-de-sac is a disaster again. Now see, this is the tragal cartilage below. This is tragal. Now you can separate the tragal further. Now this will be reinforcement to what we have done laterally. See the tragal behind and the conchal anteriorly. See this conchal cartilage here behind and the tragal pulled from anteriorly, and that is the canal skin underneath. And see now what is being done. This tragal to conchal suturing, this will close the skin canal from below. So nowhere, this is reinforcement to prevent breakdown. The challenge comes in situation where we are doing this in patients who already have myoplasty done, cavities, where we are doing subtotal preoperative and implantation. In those scenarios, we don't get a conchal cartilage. Most of the time it has been removed and after the myoplasty. Tragal cartilage we don't get enough sometimes because it's used as a cartilage graft. In those scenarios, we make a posterior auricular artery inferiorly based flap, soft tissue flap, and reinforce the canal suturing from below rather than cartilage suturing. See now, everything closed, completely closed. You don't see any canal from inside and outside, and that is a perfect cul-de-sac closure, we believe. बंद कर दो यार किसका फोन बंद कर दो. Hello, auditorium.
Yes, we are listening.
Khanna sir, any questions from anybody regarding cul-de-sac?
So this is the first step we do in subtotal preoperative.
I remember we did a case of subtotal preoperative at Khanna sir's place in Karnal in his workshop. That too was a child.
The CSL.
Yes. See now what I am doing, undermining the skin. See this, undermining the skin flap from behind. See this? So this is simple undermining. And now I am going to raise a superiorly based flap to cover my implant and expose the cortex. इधर लगा retractor है. एक यहाँ लगा दे, एक और ले, उधर उधर पकड़ के. See this? See what my assistant is doing? Pulling the pinna anteriorly with the stay sutures. See this? So you don't need to use retractors throughout the surgery. Now this is the mastoid tip here. See this? What we are doing is making a flap here. See, making the flap here. This is bone deep. This is anterior incision of the flap. This is on the cortex. This is a random flap. Work on the principle of 1:2 for vascularity. It's not based on a single vessel. It's a random. बाइपोलर किधर है? So, see my flap incisions. This flap incision, the lower one, going posteriorly and wide and wide. As I go above, the incision goes more wide to create a broader flap to prevent the necrosis of the flap. That's a simple strategy for any random flap. And now, see, this periosteum is tightly tethered on the cortex. So be careful. The periosteum is part of the flap. Periosteum has to be thoroughly elevated. You can see the periosteum coming up. Can you? Hello? So that's the random flap where I am going to secure my implant underneath. This is going to come over the implant. Okay? I can further elevate if you want, if needed. Knife. उठाए आगे आगे. This is based on branches of superficial temporal from above, branches of occipital from behind, and branches of middle temporal artery, and a lot of other communicating branches. So this is a random flap, simple 2:1 principle.
So, sir, while dissecting, if we inadvertently injure the branch of the superficial temporal anteriorly,
Yeah, may compromise.
we still have some vascularity.
May compromise, but that's not the only vessel supplying this. पहले वो कर लेंगे अंडर में. Now, another important thing to be taken care of. At the end of the surgery, when we resuture, when we resuture, because of the tissue elevated, it falls short, shrinks. And ultimately you are left with tight suturing, and that is not acceptable. A tight suturing over the implant can break down. So what I am doing here now, right now, the dissection so that the bleeding doesn't happen after the implant and the cautery need doesn't arise. I am doing little undermining for the future suturing. See this. This has to be done in the beginning of the procedure of the subcutaneous tissues.
Okay, this is the very important step. When we close the suture line,
Yeah.
very important.
Tight suturing is a disaster sometimes. It may open up the,
Yeah, it gains usually.
yes, and in a post implant scenario, we can't afford the infection. So all around I am releasing a little bit.
Moreover, it supports the implant itself. So that is a good thing to do undermining the skin.
Yeah, no tight suturing should be there anywhere. See, this will close like this. Best part is the occipital artery and its branches come from deep to the mastoid tip. So whatever flap you elevate, whatever drilling you do, it doesn't bother the occipital artery at all. Doesn't injure the occipital artery. Now anteriorly also. Undermine karna. उठा. So undermining everywhere to release the tissues. See, to release the tissue for suturing. See how much the tissue is released. See? So now it will be sutured easily. It is not going to fall short. Agreed?
Yes.
Now, suture marker. Now 3 more stitch sutures with no use of retractor. And now our cortical drilling will start. इसको fix कर देना. So the technique of subtotal petrojectomy, as I mentioned, involves time क्या हुआ actually? It actually involves exentration of all cellular tracts from the temporal bone, and for that you need to have a thorough study of the CT scan. It has to be on the DICOM to define if there are any petrous apex cells, if are there any infracochlear cells, peritubal cells. All those hidden areas have to be thoroughly explored so that you can exentrate them. So we will show you this kind of exentration will give you 100 times better exposure than a radical mastodectomy. So in cholesteatoma scenario, you can't leave the cholesteatoma behind with that exposure. You give your verdict at the end of the surgery about the exposure if one can leave the cholesteatoma. Concern is not the cholesteatoma, concern is the cells left behind with mucosa in it, giving mucocele. So you have to exentrate all, keeping the labyrinth intact. The entire labyrinth is going to remain undisturbed during the entire procedure. So subtotal petrojectomy doesn't, allow the labyrinth to be touched even. Tooth forceps. You can. Now we have to remove the canal skin and mucosa from everywhere. See this. You can. तो पकड़ना. Suction रखिए. See, I am removing this lateral part of the skin of the canal. See this lateral part of the canal? To ensure that no lateral epithelium remains. This is something important. Otherwise, at the side of the canal cut, one can overlook and leave the epithelium behind. That could be a disaster. See, this is just the lateral skin I have removed. Now all skin, mucosa, cells, everything has to go And see, this doesn't affect the prospect of cochlear implantation. In a regular implantation, once implant is in place, it gives electrical hearing directly stimulating the inner ear hair cells. So the middle ear and the external ear do not participate after the cochlear implantation anyway. So accentrating, ablating the middle ear, external ear, all these things doesn't affect the prospect of the implant anyway. That's why in high risk situation, this technique is amazing.
Sir, nowadays a new concept of hybrid implants has come into play.
Yes.
The low frequency hearing is being taken care of by the
Yeah.
hearing aid and the high frequency by the cochlear implant.
Yes, low frequency by hearing aid, high frequency by implant, hybrid implant, and this technique is a contraindication to that. Here you obliterate the canal, you close the canal, so you cannot use the hearing aid afterwards.
Yes, sir.
ये लगा दे, सूचर लगा दे. See now the mastoid is completely exposed. Remember how narrow our incision was, how the incision line was so small, just following the regular post-auricular curve. Yet we get this much of exposure because of undermining and flap raising. Okay? Now we are all set for drilling. Drill. So now you have to go radical. अरे कवर लेंस का क्लीन करना. This is my most robust. ये निकल रहा है, लूज हो रहा है, प्रॉब्लम है क्या? This is my most robust conical burr for the cortical work. See the, can you see the sigmoid sinus?
Yes, sir.
Now I am, see, accentrating all these perisinus cells. That is sigmoid sinus.
Yes, sir.
I can see the glimpse of the tegment. See, this is pre-sigmoid plate, flat plate, all cells removed.
So, particularly in this case, one more side,
Yeah.
we have to be very cautious regarding the drilling part. Any comment from your side?
Drilling part,
The drilling part in a child of 1 year age.
no different. The reason being, I tell you, the middle ear of anybody is of same size and dimensions and maturity like as an adult. My middle ear is same what it was at the age of 1 year, at the time of birth. It doesn't change. What all changes? Yeah. So mastoid is not present at the time of birth. Mastoid is not a developmental structure. Mastoid forms later on with the fusion of see there was some glue. The fusion of tympanic and the petrous portion of the bone behind. So the things which change after the birth, things which change after the birth is the curvature of the axon-auditory canal and the dimensions of the mastoid. Here, this is important. Now see in 1 year how good the mastoid is. The facial nerve, the facial recess even is same size at the time of birth what otherwise it is in adults. Doesn't change at all. What all changes is the mastoid process, dimension and the curvature of the axon-auditory canal.
So the exit of the facial nerve and the carriage after foramen is changed after Cholesteatoma.
Yeah, the facial, no, since there is no mastoid at the time of birth, so it is superficial. When the mastoid process develops, it goes deeper and deeper. See here now I am using diamond to ensure that no peridural cells left. See this? Perisinus, peridural. I don't want to leave any cellularity behind. This is pre-sigmoid. And this is the sinodural angle. The actual sinodural angle by definition is a deeper structure where the superior petrosal sinus joins the transverse sinus. See these are certain hidden areas which have to be thoroughly dealt with. भाई वो देना वो बोन वेट भाई बोलो You know, there are many ways to control bleeding in lateral skull base surgeries. For all soft tissue bleedings, we have either Surgicel or the bipolar. For all bony oozing, either we have a dry diamond drilling or the bone wax. Cutting there. See now, this is the glimpse of the lateral canal. As I said, the labyrinth. See the mastoid tip I have already excentrated. Now the canal. Clean कर छोटी दे कटन
So it was signals such as myself. At this point, should we be identifying the incus first and then go down?
Incus is removed. See what I see here now is our lateral semicircular canal. and I can see the glimpse of the facial now in the lap of the lateral canal. I will show you. And following the facial now, I am going to remove all this bone anterior to the facial now. That is anterior thinning of the facial now. This is wax in the canal, Kar diya. See this? The wax removed. Glue I removed. See, I am following the fallopian canal now. This is lateral canal. This is anterior thinning of the facial now. Anterior thinning. See the glimpse of the fallopian canal. Now, see this? This is tympanic bone. This is part of the tympanic bone. There's the axonometry canal. I'm widening this, see? Bony canal drilling. We have to remove all this flap, remaining flap, tympanic membrane, everything. Everything has to go. See anterior thinning of the facial now, hypotympanic exposure. Pick them. वो देना. See the fallopian canal. See the fallopian canal? See the fallopian canal? Very clear? That's the facial now. And now I am lowering the facial wrist to the level of the facial now. See how the facial nerve is. This is optimum lowering of the facial ridge. Otherwise, people leave it many a time for the fear of the facial nerve, high. Two things are important when you contemplate a canal down mastoidectomy. See this, what I am doing, flushing the canal, this mastoid with the hypotympanum. So even in a good canal down mastoidectomy, you have to remove all this part of the tympanic bone to flush the hypotympanum. See the hypotympanum? Flush with the mastoid, and that is possible only if you, do the adequate lowering of the facial ridge. For the fear of, facial nerve injury, you don't lower it adequately. That is one of the reasons for a persistent discharging cavity. See how much I have lowered.
Yes, sir.
I am using this burr as a brush. I am still using the cutting burr. This is more safer. Doesn't produce more heat like diamond burr produces. And now see, I am further widening the middle ear side. Once you know the facial course, you can widen more and more anteriorly to adequately expose the hypotympanum. See how much anterior thinning of the facial nerve is required. The hypotympanum is completely marsupialized, you can say. Here in doing this thing is the facial nerve. So if you know the course of the facial nerve, delineate it, and you can really do adequate work without complications. This is my fallopian canal. See this?
Yes, sir.
And this is hypotympanum, circular. Now what I am doing is removing this tympanic membrane. The malleus now. See, this is the tendon on which the malleus is forceps. The stapage is there. लेजर लगा लेना. See the middle ear side. Now diamond depth छोटी देता है. चलो. First I will accentuate the mastoid work first and then go anteriorly. See, I have a full view of the facial nerve. Fallopian canal completely. See, I am removing the bone anterior to the facial nerve, and that uncovers the round window region now.
Yes, sir.
Now, this exentration first to move anteriorly. This is perilabyrinthine drilling. There are a lot of cells around the labyrinth, and you are supposed to, thoroughly excentrate them.
So, sir, perilabyrinthine drilling is required in each and every case of cholesteatoma when you will go for a canal wall down, or is it just for a subtotal fixation?
No, canal wall down is different. Canal wall down, we don't have to, do this cul-de-sac, this and that and all that. Yes.
Just about the drilling.
Yes, drilling, we should adequately lower the ridge like what I have done. We do use a vascularized flap in the cavity to prevent leaving a raw bone. So we always excentrate this mastoid tip and allow the occipital artery brace flap to come inside. But yes, drilling has to be thorough. You don't have to leave behind the, mucosa to suppurate. Excentrate. Since we do not obliterate the Eustachian tube in canal wall down, we are not supposed to chase the peritubal and all those Peters apex cells, because they are going to be aerated down the Eustachian tube. But behind this mastoid work has to be thorough. I will show you once I come to that. You take the peritubal pericarotid cells.
Okay.
See, this is pre-sigmoid dura. This is sigmoid, this is pre-sigmoid dura, and this is the labyrinthine block.
Yes, sir. So please, any experience regarding the explantation in such cases or any biofilm in such cases?
Not really, because that's why we are doing. See, we are not leaving any avenue for future infection coming to the temporal bone. Infection happens to take place in the place of the implant, in the presence of the implant, then biofilm will attract. But since we are blocking of Eustachian tube, we are blocking of cutting blocking of exonotory canal, we are practically blocking of all external sources of infection coming to the temporal bone. So the chances of biofilm are negligible now. We rule out the biofilm possibility now doing this technique. See the supra labyrinthine cells. All along the tegmen I am drilling off. Now more challenging areas ahead around the carotid and the Eustachian tube will come to. You have to skeletonize the important structures. See, I have skeletonized the pre-sigmoid dura, skeletonized the tegmen, skeletonized the semicircular canals. See, this is lateral canal, this is superior canal above. That's the superior canal. Below is the marrow space, not the cells. You are not supposed to excentrate the marrow space at all. That is a part of the, see below as you go deeper, that's a part of the occipital bone that contains the bone marrow. This is, can you see the perforated bone kind of a picture? This is marrow bone, and see below that is jugular bulb. Can you see the glimpse of the jugular bulb?
Yes, sir.
Below. That is the limit. And see what I am looking at here above is the posterior canal. That is the posterior canal where my burr is. So exentration of cellular tract means complete exentration. Diamond थोड़ी छोटी. See, can you see the skeletonized things everywhere?
Yes.
This is called exentration. See, this is, see the jugular bulb.
Yes, sir. So I believe the enterostatic tract is also going.
That is a structure deep to the bone which I am not removing, the plate of the bone, that is not warranted. Now see the skeletonized semicircular canals. This is superior one, this is lateral one, this is posterior one. And everything in between removed, all cellularity. This is called Perilabyrinthine drilling. This is the dura. This is supralabyrinthine drilling. See, under magnification, you have to follow looking at the CT scan. CT scan is must to as a guide to know. Now coming anteriorly, cutting that. Now the middle ear, see so much of mucosa and cells. There. Now, you see the fallopian canal is going up. Below this was the tendon from where we remove the malleus. That is the tendon of tensor tympani. And it comes in a canal running above the carotid. That is tensor canal. Now, we know this is cochlea, this is promontory, and just anterior to the promontory in closest proximity is the carotid artery. And there are number of, see this is Eustachian tube orifice there. There are number of cellularity around the Eustachian tube and around the carotid. So we have to excentrate them as well. And entire this middle ear mucosa, infralabyrinthine cell, all around have to go. See the glimpse of the jugular bulb from front. Can you see? Very clear? This jugular bulb from front, this jugular bulb from behind. This one. This one. And this is bridged crossed by facial now. That's why in glomojugular surgeries, when you deal with the jugular bulb, you have to transfer the facial now. You know? Now, important thing, bipolar. Wherever you cannot ensure a complete drilling and removal of the mucosa, what you can do, you can devitalize the mucosa using the bipolar. Non-functioning mucosa. See this? See mucosa around the stapes, see what I am doing? Cauterizing the stapes. See this? See? The oval window mucosa cauterized. Similarly, round window mucosa.
So what about the cases where there is a facial nerve anomaly, maybe a low hanging facial nerve?
Facial nerve, see this exposure, with this exposure I mentioned during the initial presentation that any challenging anatomy, distorted anatomy, this is the best approach because now you have open book. See now everything is open for you. You can deal with any anomaly, any abnormality. See the mucosa entirely I excentrated.
So even inner ear anomalies can be taken up for
Pardon?
even inner ear anomalies such as maybe an incomplete partition.
This is ideal for them. This gives the opportunity to obliterate the cavity to prevent CSF leak. Additionally, see this, I am excentrating all these infracochlear cells after cauterizing the mucosa. Can you see the flush infracochlear region? The carotid here, the jugular here and carotid in front. We'll show you soon. That's a glimpse of the carotid artery. Now, this is the tensor tympani canal above. See this canal? I will open the canal and I will cauterize this. Bipolar. वो लगा रही है क्या लेजर? See the tensor canal? This mucosa in the Eustachian tube region, again I have cauterized. See this? Now the most important area, peritubal area, pericarotid area, and obliteration of the carotid, the Eustachian tube. This has to be, done very carefully as you are around and dealing with the very critical structures. And another important thing, if you simply obliterate the Eustachian tube, there are distal, connection of the Eustachian tube to the cells in the temporal bone. So distal pathways still remain intact in spite of obliteration of the Eustachian tube. This bony tube is 1 centimeter only, and the cartilaginous tube is double than its size. The bony is around 12 millimeter. And if you obliterate only from laterally from the medullary side, those connections from the distal, pneumatic tracts are still remain intact. So our concept is elimination of the bony Eustachian tube to ensure no future connection remains until you reach to the cartilaginous tube, and then obliterate. That gives you 100% confidence that no connections are existing. Okay? This
distal connection you mean distally in the bony canal, not in the
to the pneumatic tract somewhere in the Peter's apex somewhere. So obliterate. Drill and excentrate the Eustachian tube completely. I will show you. See this? The Eustachian tube forms the lateral wall of the this bone forming the lateral wall of the Eustachian tube I am drilling off. In the medial wall of the Eustachian tube is carotid. So I am drilling this bony wall, lateral wall of the Eustachian tube thoroughly. See now. Confidently, without any fear of carotid, because that is supposed to be in the medial wall. See this? Bony Eustachian tube I am completely eliminating. This is something we propose in addition to what Mario Sana does. See what I am doing? Completely drilling the Eustachian tube. Completely means completely. Bipolar. Over there, circular there. See, this is all mucosa, which I have cauterized. all this mucosa in the tubal and peritubal region. See this much of mucosa. It is, if you don't remove it, it is a persistent source of problem. Your entire surgery can fail. Drill. See, I am working over the carotid artery now. Here is the carotid in the floor where I am drilling. See this? Change of color. And I am just drilling all these cells around the carotid until you get the fresh bone, flushed. Coblation. Coblation doesn't reach so efficiently there. See the glimpse of the carotid artery. I am drilling right over the carotid. See the carotid in the depth, this one. Can you see the flush bone of the carotid canal? And see all these cells. These are pericarotid cells, the most bothersome.
This step is also very important for the surgery of primary cochlear canal.
Yes. Once you obliterate the Eustachian tube, you have to ensure this. See this? See the carotid in the floor, this one. This is the carotid canal. Can you see the color change?
Yes, sir.
See in the infracochlear region. This is cochlea. This is jugular bulb. See behind.
Yes, sir.
This is jugular bulb till here, and this is the carotid artery coming from anteriorly. See the exposure. Under vision, you exenterate all these cells.
Yes, sir.
Okay?
Yes, sir.
Now, further Eustachian tube. See so much of mucosa. See, staying lateral to the carotid. Now, I can see the carotid in below.
Yes, sir.
Staying lateral to the carotid, I am drilling the Eustachian tube walls. This is cartilaginous Eustachian tube, this one. This is cartilage.
Yes, sir.
See, this is Eustachian tube cartilage, this one.
Yes, sir. Yes.
See how much the Eustachian tube I have drilled, that your carotid is falling in the, looking in the center of the, exposure. Carotid we do not see in the middle ear surgery. Because of how much bone I have drilled anterior to it. See this? This cartilage.
Yes, sir.
Again.
Sir, I'm wondering, do you ever get patients complaining of pulsatile tinnitus after a subtotal pituitary?
The pulsatile tinnitus is a different etiology. Why after subtotal petrosectomy?
So because of the bone underlying between the Eustachian tube and the carotid seems to have thinning down.
Carotid is never a primary source for pulsatile tinnitus. See this now, this is cartilaginous Eustachian tube. Can you see?
Yes, sir.
See where I am blocking my obliteration of the Eustachian tube. I have drilled off the entire bony tube. So no question of distal communication of the pneumatic tracts to the Eustachian tube remaining. Can you see?
Yes, sir.
Complete obliteration, exentration of the Eustachian tube. No more Eustachian tube. Bony.
Yes. Yes.
In the medial wall is the carotid. Here, see this?
Yes, sir.
Lateral wall for more than a centimeter. See? I drilled off and I have seen the cartilaginous tube. And see pericarotid, peritubal cell. Can you see any cell now? All exentrated.
Yes.
This is the prerequisite for a subtotal petrojectomy. Now finally, where are the cells remaining? Where is the mucosa remaining? I will show you. The oval and round windows. See this? This one?
Yes, sir.
So you have to do something to the windows also. See, this is the space above this tensor tympani canal. See this?
Yes.
Part of the anterior atic. Now these canals, windows are challenged. So in order to accomplish the mucosal exentration from the windows now, again my exposure. Can you see the sigmoid jugular bulb below?
Yes, sir.
I am removing this overhang. That's the cochlea.
Yes, sir.
Then right angle. See all this mucosa.
Yes.
See the round window niche.
Yes, sir.
पतली देना बिल्कुल टिप वाली बार. The round window is looking little ossified, whitish. See, I am removing all this mucosa
Yes, sir.
from the round window side. Okay.
Yes, sir.
Now लगा दी क्या लेजर?
Sir, at this point, could you please share any experiences you've had with cochlear trillers?
Yes, many a times. Will show you also a little bit. हाँ लगा. So now I am using laser to remove the stapes suprastructure. This is mobile stapes. How can you remove mobile stapes? If you try to cut, if you try to, do anything, drill anything, mobile stapes is going to give problems. So I am using laser here. Claudia? So in a minute's time, we are fixing the micro manipulator, and I am going to use my luminous laser over it.
You have to laser, right?
Yeah, so it is 11:38. Will be through by 12 o'clock. 12:15 maximum. So you have adequate time to get ready with lunch and all to leave before 1 o'clock. हाँ क्या हुआ नहीं लगेगा लगा so just we wait for a minute for the micro manipulator to be fixed. Any questions meantime?
So how would you tackle a case of ossificans?
Ossificants drill out depending upon the how much the cochlea is ossified. See, initial ossification starts close to better sir, better close to round window
Okay, sir.
because the infection is supposed to enter through the cochlear aqueduct, which is open close to the round window. So initially it involves the scala tympani of the round window. Then it progresses to the scala vestibuli of the basal turn, then to the other turns. So in initial classifications, we can deal with drilling the scala tympani of the round window area, basal turn. If it is completely ossified, not possible to find lumen, then you can find the scala vestibuli from the oval window side and implant in the scala vestibuli. Because scala vestibuli is last to ossify. If all the turns are ossified with little bit lumen, you do a complete drill out and use multiple electrode array in different areas to stimulate maximum electrodes. That is what we do. We have in a theater Dr. VP Singh और VP Singh सर ने कहा कि बंद करो तुम्हारे नाटक सर्जरी का. There is no surgery, there will be only cricket. उन्होंने धमकी दे दी है साफ, ये सर्जरी के बकवास नहीं, हमको सिर्फ क्रिकेट के लिए कहा था. और साफ तौर पे उन्होंने खुलेआम धमकी दे दी है कि ये सब नाटक नहीं चलेगा कल से. पचौरी बहुत समझाओ. Tell me he wants to play more and more cricket only. क्या करें इनका? I don't know how we bring so much of energy at 59. I तो बोले मैं और क्रिकेट खेलूंगा. He is not in mood of any retirement. He is in mood of kicking out Rajiv Pachori as a captain and leading the team. खन्ना साहब, खन्ना साहब खुद अपनी टीम के झगड़ों में जूझ रहे हैं. खन्ना साहब खुद जूझ रहे हैं अपने उपकप्तान से.
नहीं मैं चाय का अरेंजमेंट कर रहा था यार.
दोनों में सुना कल बहुत तकरार हुई है, कप्तान उपकप्तान.
हाँ कहाँ नींद है नहीं, वो इतना नाराज हो गए कि अपने रूम में ही बैठे. उससे सब आ गया.
So I think this all will benefit Melius team. लग गया? लगाओ. हाँ सर.
ये स्ट्रेचिंग करवा देना, देख सारे थके हुए हैं. एक सेशन स्ट्रेचिंग.
आज रखते हैं ग्राउंड पे.
रीचिंग द ग्राउंड.
Okay, we'll keep.
We will have a stretching exercises.
Yes.
Again, our boss is Satish Jain.
Yes,
For this
पक्का.
also, he is a stretching coach.
Done. We'll do together, all together. ये लोग बोलो.
हाँ लेकिन एक है भाई, हम लोग को ना एक बड़ी अजीबोगरीब सी फोटो मिली थी व्हाट्सएप ग्रुप में.
हाँ.
जिसमें वो चार कुछ चढ़े हुए थे किसी के ऊपर. अब सबका कहना है कि उतने तो नहीं कर पाएंगे, एक आध बहुत है, वो भी
नहीं, we'll keep definitely a stretching session. That will be good for everybody. And ideally we should do this before every match.
लेकिन आज के मैच में बहुत जरूरत है, मतलब आफ्टरनून मैच में बहुत जरूरत है.
आज का मैच vestibule. See, vestibule don't take. See,
Raise your hands, please.
Incus,
You are
In,
waiting for
In,
you all.
Incus has already won 2 matches. They are in overconfidence, and majority, majority are in are with vestibule team today.
We are underdogs and we are
No, no, you already won 2 matches. So now it is a time for the cochlea and vestibule to lead. Cochlea is likely to bounce back.
we can fight for your place in semis.
So since Incus has won 2 matches today, everybody will be favoring the vestibule. We want vestibule to win today. वो कहाँ है लाइट
So, cricket is a silly game and anything can happen.
कहाँ है लाइट नहीं आ रही हाँ अब आई अब आई अब आई अब देखिए रुक रुक हाँ इधर है So I am setting up the laser.
Sir, like in an MLS, when we use the laser, we take certain precautions. We use a different kind of tube, we provide additional padding, we put a subglottic patty. In the case of ear, where we use the laser, what are precautions are we supposed to take?
Hardly any required here in the all around there is bone. Only thing is when you have a telephone there when you have a bare facial nerve, dehiscent facial nerve, you have to be careful. The laser fire in the vicinity can heat up the facial nerve and give energy, damage. So that's the only thing. In that scenario, what you can do, you can cover with the wet gel foam. This CO2 is absorbed by water. So wet gel foam, wet goes is like a, shock absorber. See now, what I am doing. See my laser beam. किधर है pedal? Ready कर on section.
So what are the settings of the laser that are being used?
I am using the pulse laser. And here I am using the
Snow in the picture, I don't know why.
pardon?
It was very clear. There is snow.
No. जरा ऑडियो विजुअल देखो भाई now see my laser is ready to fire section दे I want to remove suprastructure by laser without giving damage. Without mobilizing the foot plate. That's the only reason for using the laser. Here I am completely vaporizing the yes. Because this is completely, we know, the mobile foot plate. See, all around also,
I think the mucosa is also being taken care of.
yes, all vaporize. All vaporize. That's what we want.
Yes.
This,
Suppose we are not having laser,
then, see, getting rid of mucosa is very difficult from this area. See this round window?
yes, we can use MLW brand here.
That won't match the laser at all. Hello, light बढ़ाओ.
Could we use a speaker drill in that?
हटा दो इसको. So we got rid of suprastructures
Burn the mucosa first.
and burnt all the mucosa. See this? That's the beauty of the laser. Now patli drill दो. The round window is little ossified. So what I am doing now, पतला दे सेक्शन पतला पतला नहीं बैठ जिम shaft of the burr is coming. See, this is long tapering shaft. Do you see? The biggest problem in the drill house is the round window is not identifiable. What size burr? This is a diamond, 0.8 mm. See, this is round window side, so oval window side. Surprising. See, after the subtotal peterectomy, whoever is doing the drill out, see my carotid is in my view. Can you see?
Yes, sir. Yes.
That is the best protection it offers. Best protection it offers, that you cannot, you keep your important structure in your view. I have to do a drill out. I don't know when this MRI was done. Huh? बॉस कब कराया था? So I am coming from the oval window side now. Pardon? जो पतला देश. I don't know. This patient was referred by Pachori boss. Boss कब किया था इसका? नहीं MRI. Yeah. Can you see now? See, the scala tympani is completely ossified. Can you see?
Yes, sir. Yes, sir.
This is scala vestibuli. Can you see?
Yes, sir. Yes, yes, sir.
See this lumen.
Yes, sir.
This is scala vestibuli. I may open up a little bit of the scala tympani now. What an interesting ossification. See this. This is series है ना. See, this is scala vestibuli. Can you see?
Yes, sir.
I came from the vestibule side after removing the oval window, and this is the scala tympani now. So it is narrower than the vestibuli. Can you see?
Yes, sir.
Because of the surrounding ossification. Got my point?
Yes, sir. Yes.
Can you see both the scala?
Yes, sir.
And this is osseous spiral lamella. This is osseous spiral lamella. There is glimpse of this ossification bones. See this? See now. Now we can find both the scala. Can you see very clear?
Yes, sir.
Wash them. That's the beauty of subtotal again. You can drill out handy at the same time. See this? Boss, dekh lo. This I am just pouring the steroids. So this is osseous spiral lamella. That is scala vestibuli above. See this? This is scala tympani. Very clear? Everybody?
Yes, sir. Yes, yes.
And this region here, I can see, this region of the scala tympani here, see this? This was ossified. This was ossified. See this additional bone? This additional bone, so I had to drill out to find this lumen.
Yes, sir.
Perfect?
So what can we do to prevent further ossification in this case?
No.
Post-operatively?
Post-operatively, once the implant is in place, that will secure the lumen. The problem comes, your question valid, sometimes the child develops, suppose, meningitis. And the MRI starts showing changes of fibrosis before ossification. Either implant immediately, gel form de de. I am covering this for a while until I make the steroid. I'll cover, and the only thing which works is the steroid here, even to prevent further ossification. See now, I kept this soaked in steroid. Now we will make a well. Today we are using the metal implant.
Is it a modulus hugging implant?
No. See, modulus hugging implants was a concept earlier introduced with the feature of keeping the implant close to the modulus. So it will stimulate more closely. The more, I would say, the required current will be less and less. So it was very, very fascinating. But for the implant to curl automatically around the modulus needed a stellate. It needs a stellate.
Yes, sir.
That makes the implant very stout, more thicker. So you take the stellate right up to the anterior wall and then pull it, and then it will curl. So the modulus hugging implants are more thicker. What happens? It looks nice, fascinating, everything. But if you try to pull the implant back after hugging the modulus, it will destroy everything. So pulling back those implants is most difficult. And placing them is very, very tricky. You have to start, pulling the stellate at the right place. Otherwise, it is more damaging. So modulus hugging implants are, in the present context, I use only in one situation. When I am operating on an autosclerosis case. Autosclerosis case means, in autosclerosis, the normal enchondral bone is replaced by the more spongy bone. That is more conducive for electrical current. So when you place the implant in the cochlea, the structures surrounding the cochlea are stimulated. Because the current passes through the porous bone and frequently stimulates the facial nerve. And that's a disaster. The implant stimulation gives constant facial nerve stimulation that is so bothersome to patient, and Many a times you have to deal with it with either switching off the surrounding implants to the labyrinthine facial nerve. Labyrinthine part of the facial nerve is very close to the upper descending portion of the cochlea. Sometimes the intervening bone is a some millimetric thick bone, or sometimes no bone. So that is troublesome, and many a time ultimately you need to explant. So modulus hugging implant in our scenario has only one indication in otosclerosis, where the implant is away from the cavity, it is closely hugging the modulus, so current diffusion to the outside walls is much lesser. Current diffusion to the facial nerve canal is much lesser. So, and you need very less current to stimulate because it is very close to the modulus. So otherwise it is not desirable in any scenario. Yes?
Is it there in all the otosclerosis cases or just
All by default in otosclerosis. By default. Though indications in otosclerosis and surgery for otosclerotic cochlear implant is very, very challenging. Finding the round window is difficult. You saw in this case the round window was ossified. See, the timing of MRI is very important. MRI picks up the fluid. Now, if some infection sets in, the fluid is replaced by the fibrous bone, the fluid intensity goes on MRI. And then quickly translates to bone. So, like if you are getting MRI today and operating 3 months afterwards, the picture may surprise you. That's what happened in this year. See the initial basal turn. I told you this ossification starts close to the round window where the cochlear aqueduct opens. So it is started there. The rest of the turn is clear. Could you see? So I drilled that and I immediately went to the vestibule. One of the opening in the vestibule in the floor anteriorly is of vestibular tympani, scala vestibuli. So I went there and saw the scala vestibuli, saw the ossification, osseous spiral lamella, and underneath we could widen by removing the bone, the remaining scala tympani. So now under vision, we'll place our implant in scala tympani. It will be cakewalk now. Insertion of the implant in such a wide open book cavity, where you see the scala tympani directly, is a child's play now. You have to just push the implant in and it is going to go in the scala tympani. Nowhere else. So now the final insertion of the implant will be a child's play.
Yes, sir.
Got my point?
Yes, sir.
Any other?
We are noticing here that you earlier told that you are using a metal implant and the sizes you are using of cochlear.
Sizer cochlear है? क्यों? ये देना जरा. अरे वो वाला साइज देना मेरे को. मेडल का है इम्प्लांट. मेडल का है. कौन सा दिया है? नहीं साइज सेम नहीं होगा. थोड़ा देना चेंज करना. गौरी, where is the? I think it is same. Why did I pick up? कहाँ है? This one. Boss, it is almost same. That's why my I have picked up. Even my assistant gave me measuring both the sizes. It is almost same. Rather the medal is a millimeter smaller. That's it.
Good observation.
Even I didn't observe. My assistant measured and gave me and I used it.
Many surgeons they don't use sizers because of their experience.
No, but we should use. Why? Yeah. The implant should be very nicely fixed onto the bone. See, I tell you, This fixation can be done by various means. You can make a periosteal pocket, you can make, other muscular, securing the implant. But this drilling the well and fixing with the, sutures, I still believe is the most secure way. The reason being, if in any given situation, if your implant gets mobilized, it's a disaster. It can pull the array out of the cochlea, and a mobilized implant can invite problem, infection, biofilm, so many things. It can perforate through the skin. So the implant should be thoroughly fixed.
Actually, can we fix the implant without making a bed? We are fixing without, we can make the holes and we can fix without even making a bed.
Pardon?
We can fix this implant of the cochlear without making a bed. We can make the hole.
Then it will project above the skin. See, an implant constantly projecting above the surface would elevate, stress the skin and ultimately perforate. That would be a disaster. That's why it should be secured flush to the bone. No more elevated above the skin. ठीक है अब तो सही.
This latest implant is thickness is lesser than the previous one.
Yes, I know they are more slimmer, but still we should make a slim well as well. Why to take a chance? See, once implant is in place and the infection sets in, is going to be disaster both for patient and surgeons. Not to take chance. A lot of people have different thinking, That's how the science progresses. Everybody has different, changes in their technique. For any surgery, tympanoplasty, everybody has a different technique. The goal is same, how we are used to comparative results, everything matters. Retractor ऊंचा करो. See, this is now medal. ना बॉस, अब medal का ये template. Now,
Yes, Dr. Satish.
उनका मेडल का ये टेम्पलेट after your observation. Yes. And now see, there is an island created that is pushed by the implant, so the implant doesn't over project the surface. So that is a strategy. Creating an island.
You have kept the part of the island just near the video made, but we can separate
Hole.
so that it can be pressed very well.
Yes. So the implant is this implant is not very thick one.
The bone will grow itself later.
Yeah, and see, every patient's skull thickness is different. In children, it is supposed to be less, obviously. So there are more tend to make this island. Now we are making tie down holes to secure the implant strongly. We'll be using nylon to secure the implant. See now, in next 5-10 minutes, we'll be through. Just tie down hole, securing the implant, putting in the scala tympani and then fat obliteration. Fat. Look. See, one side tie down holes have been made. That is other side. This is being used as a guard. Periosteum elevator being used as a guard so as not to perforate the dura. We'll put a wash, thorough wash. Just remove this bone dust. We are all set to put the implant now. And in 5 minutes, I think we'll be through. I think the lunch is being served there inside the hall.
Yes, sir. Yes, yes. Lunch has been served. Lunch was already there at around 11. Just because of your, you can say, मतलब इतना terror है, so patiently उन्होंने 11 बजे ही जो है वो lunch prepare कर दिया.
My God. We never asked for 11, at least 12. So the goal is to leave before 1 o'clock. We'll have half an hour to spend on the ground before the match for our,
Suture are you using right now?
proline. 2-0 proline.
Okay, sir.
Now 5 minutes job left. Just secure the implant and put inside. That's it. Lena. Set. Jaldi. Kya hai rifampicin? Here. Oh, this is very frustrating job. The last 15 minutes, what we are doing is all mechanical. You have to drill the well, tie down holes, threading. Sanna boss? Hello?
Yes, please.
पता है आपको किस साजिश का खुलासा हुआ है?
हाँ बताओ ना यार.
कल रात को पचौरी बॉस ने जान के वीपी सिंह जी को रन आउट कराया है. So he gets out, he doesn't score much, gets frustrated and take retirement
Oh.
and leave him forever.
लेकिन अभी पचोरी को ये भी नहीं पता कि डॉक्टर वीपी सिंह जो है किस मिट्टी के बने हैं.
ये तो आज तक
कभी रिटायर होंगे ही नहीं.
पर ये ऐसा चाह रहे हैं.
रिटायर हो जाएगा लेकिन वो नहीं होंगे.
ये इनको बिल्कुल
ये थोड़ा गलत फहमी में है मतलब.
हाँ इनको बेदखल करना चाहते हैं ये.
हाँ. ऐसा ना हो उल्टा पासा उल्टा पड़ जाए.
वो रन था ही नहीं, जबरदस्ती भगा दिया इन्होंने जानबूझ के रन आउट कराने के लिए.
मेलेस की हालत ऑस्ट्रेलिया ऐसी है.
अच्छा एक और न्यूज़ है फ्रॉम दिस हॉल दैट वेस्टिबुल टीम हैज ऑलरेडी लेफ्ट फॉर द प्रैक्टिस. इतने टेरराइज हो भी रहे कि भाई पता नहीं इनका से मुकाबला करना है तो कैसे करेंगे.
इंकस जो ओवर कॉन्फिडेंस में है ना, आज जो मैं बता रहा हूँ, फुल फोर्स इज विद वेस्टिब्यूल.
मतलब ऐसा See, we wish to have a fair play award, our team in Kurs. So जो भी हम ग्राउंड पे कभी भी स्लेजिंग नहीं करेंगे. हम लोग बाहर कुछ नहीं कर सकते हैं. लेकिन
नहीं, हम तो ग्राउंड पे भी सुन रहे थे आपके रूप कप्तान की जो की बहस हुई थी.
आपस की बात अलग है. अपोनेंट टीम को कभी स्लेज नहीं करते. हमारे खून में ही नहीं.
नहीं, हम तो मन ही मन तो करते हैं. हम मन ही मन तो करते हैं, बाहर से नहीं कर रहे। वॉश 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 सिरिंज, मोटा सेक्शन दे, मोटा सेक्शन।
हम लोग ने बचपन में डंडे खेले
उठा
हैं,
उठा।
बच्चे जिसको कहते थे हम लोग।
हाँ
तो वो बिल्कुल जो है, जो बॉल है गुड लाइन से रहती थी, बस उसी का हम लोग को थोड़ा फायदा मिल गया, जो बचपन तक खेला हुआ है।
सब लोग बोल रहे हैं जो हरियाणा से टीम आई नहीं, कभी भी आपस में लड़ मर सकते हैं, इनको ध्यान रखना, इनमें नजर रखना।
नहीं, ऐसा है कि आपस में लड़ मर तो सकते हैं, लेकिन उल्टा
दूसरों से भी।
भी कर सकते हैं हम लोग। तो बी मतलब प्रिपेयर्ड फॉर दैट आल्सो।
हाँ, वो हरियाणा वालों को सब मान के चलते हैं, थोड़ा बहुत प्रिपेयर रहते हैं।
लेकिन हमारे साथ पंजाब भी है, हिमाचल भी है, तो वी आर इन कंट्रोल। हिमाचल ठंड भी है शिमला वाली, और गर्मी भी है हरियाणा पंजाब की। बैलेंस है, यस।
और कल एक सरदार के आने से और माहौल बन गया। एक्चुअली टूर्नामेंट में सरदार नहीं होना ना।
पहले सरदार बताओ कौन था?
हरिंदर जी, हरिंदर जी। इम्प्लांट इम्प्लांट। या पर मैं कह रहा हूँ टूर्नामेंट में जब तक एक सरदार नहीं हो ना, बात बनती नहीं है। लास्ट 24 आवर्स ना, हल्के में मत लेना वेस्टिब्यूल को।
एक्चुअली वेस्टिब्यूल का कोई भी नहीं यहाँ पे, तो कुछ भी बोलते हो, सब माफ है। है ही नहीं कोई यहाँ पे।
इम्प्लांट इम्प्लांट दो भाई, इम्प्लांट। So they are terrorized by the performance of Incus team. See this befitting? उठा। उठा, सेट हो रहा ना? कहाँ गया? कहाँ गया?
1 मिनट की बोल चुके हैं, तो 1 मिनट बाद
इधर उठा इसको। See this figure of 8 suturing. दोनों उठाया, दोनों लगा। जल्दी आ, दोनों उठा। This figure of 8 suturing. यस, यहाँ नीचे नहीं आ, पीछे पकड़, ये पीछे और पीछे, एक को पकड़ना है उसको खाली। खुल गया ना, लूज हो गया।
What should be the ideal management of this node? Because later on, when you have chosen, you have kept it under the body, even then still it comes up.
No, I will tell you. I will show you. पकड़ इसको दबा।
So no, I am
लूज
knowing
छोड़
that
दे।
I am having a stitch in the mastoid cavity, I am putting it and
No, this thread can be a disaster if not properly buried. It can perforate through the skin.
you have to act into it.
Yes, and it can invite biofilms. So I'll show you how to manage with this. We always do that.
You keep the under body, it still comes to the
No, rarely. We have never seen. I'll tell you the technique. I will bury this thread. See my yeah. So see now. Satish cell दो, वो दो. See, this is my knot. Now I'm pulling it in the hole and fixing it to invite fibrosis. To invite fibrosis with the surgical invite fibrosis. No, I always use surgical. See this? This will invite fibrosis, totally inverted, and now it is not going to come out for sure. Now it is ready. जल्दी देना, 1 घंटा लगा दिया steroid this steroid. See, companies recommend not to use cautery after the implant is opened. Though the recent studies have proven this thing wrong, but still we have to follow the company's recommendation.
Why they were saying earlier on that we should not use it, that it was damaging the electrode?
Yes. Then the same field electrode may get deactivated.
Because they are saying it's not correct.
No, literature. Watch all the. See my scala tympani opening below. This was the site of ossification. Saline. पतला दे, पतला लगा. Yes, very nice. बस कोई दिक्कत नहीं. Now, the implantation, I told you, it's child's play. You don't have to do much. The forceps there.
So routinely you are injecting dexamethasone in the scala tympani.
Yes, that's the only thing which protects the, residual hearing system.
And also very easy insertion.
Yes, insertion is, see the area is in front of you. That is because of the exposure. Insertion is easier because of the exposure now. We don't use hyaluronic acid. See now?
Yes, sir.
The plant of the medal is very long, electrode is very, very long.
Section. See, my entire array is in.
Yes, sir.
So while doing insertion, this step should be done under a less magnification, that is 4M. Then you can go into the 8 size, 4. Otherwise you face a lot of problem during insertion.
थोड़ा पेरियोस्टम देना. तो फैट दे दे, छोटा टुकड़ा.
So usually we see that green or black colored mark and we insert it in the round window.
It's not needed. I tell you, I do not need it. I tell you the real story about stimulation and the frequency range. We human beings hear a frequency range of from 0 to 20,000. And that 0 represents the apex and 20,000 represents the scala tympani region. Okay?
Yes, sir.
Pick there. Now, these commercially available implants, they have a limitation. They stimulate a frequency range from 75 to 11,750. They do not stimulate the region 3 to 4 millimeter from round window at all, which is representing more than 11,750 range. So there is no point in inserting implant in that region at all. Similarly, from the apex, for two regions, there is no point in inserting implant from round window beyond 24 millimeter. Beyond 24 is a very small, lumen. If you try to push implant, this is going to damage everything. More damage and less benefit, number one. Secondly, the neurons from the apical turn, they project vertically down towards the middle turn. So if you have an insertion, say more than 450 degree, that is the basal turn and most of the middle turn, you don't need to insert implant beyond that, because that part of the electrode is going to insert the neurons projecting from above, from the apical turn. There is no need to insert in the apical turn. See how I am obliterating with the fat. See the tight fat. See this? Self-holding. बंद है यार, आवाज नहीं आती क्या? मोटा दे दे। This is, they keep the extra cable for the mastoid, development. See this? My middle ear, Eustachian tube region, around the implant, everything is covered by the fat. This fat is soaked additionally into rifampicin to prevent this airborne staph infection. So now we blocked off all external connections. We did a cul-de-sac closure. We have already obliterated the Eustachian tube. Implant is there in a very, very sterile zone and now being covered by the fat all around. Fat is a preferred material than muscle. I tell you for the reasons. If you ever want to see the status of the fat and the disease underneath, you get a fat suppress MRI. The fat sequences will be suppressed and you can look for the disease. Yeah. We'll put some more fat and that part is over. So, if you use a muscle, the muscle heterogeneous intensity of the vascularity of the muscle cannot be suppressed and it is difficult or rather impossible to differentiate the disease from those intensities. So, fat suppress MRI, you suppress the fat and everything will see clear. That's why fat is the preferred material. We soak in rifampicin and use it. We'll do NRT also. Now.
So are these implants that we use right now, they're MRI safe?
Yes. All. I think most of the implants are 3 Tesla compatible.
Madam, we have not removed because magnet stands on the X. So there is no need for removal of the magnet.
Yeah. These are all, mobile magnets inside. So rest are coming. So we have already checked the impedance It is good. Any questions before we wrap up? Hello?
Yes, sir.
Any questions before we wrap up, sir? So,
Yes, sir.
thank you. Thank you.